May all become happy. May all be free from illness. May all see what is auspicious. May no one suffer. Peace, peace, peace. The essence of the shloka echoes through every corridor, department and room of India's premier medical institution, Lilavati Hospital and Research Centre. The mission at Lilavati Hospital is to provide affordable healthcare of international standard with human care.
Okay. I'm finishing job now.
Yeah. Please. Let's come up.
Normal.
Okay, so we are back in Mumbai. So you remember that we continue with the first case of this morning. He has removed the stent, and now he's back again with a different stent, another silk. He's going to deploy for the time being.
I think finish open here.
So obviously he decided to change a little bit
The strategy.
because there is no gel catheter. So after deployment of the silk of the Leo, he's going to move with the catheter and go through the strout and deliver the coils.
No joke, no. That was not what we have done. There is no jailed microcatheter, and there isn't any coiling that we will do. This is a flow diverter. We changed the strategy completely. Went from plan A to plan B to plan C actually, and we checked the cross flow first. You show us the ACOM.
Charlie.
So what you're seeing is we checked the cross flow. Even though the contralateral A1 is small, we changed the strategy completely, and we came in with a flow diverter, which we have delivered from middle M1 down to the cavernous. A little bit too long, but I guess it was required because of the fusiform secular nature of the aneurysm. And we have deployed it now. And so now the challenge is we have to see if it is fully apposed in the proximal segment. Distally in the supracranialoid, it all looks okay. And so the deployment is over. Let's go to the fluoro. Okay, so this is where we are. Proximally it looks opposed. Distally it is opposed. Supracranialoid it is good, and cavernous it does not look bad. So what I'm going to do now is that I will release the distal wire and come out with the catheter which delivered the stent, what's the name? Headway. And then we will see if we need to go back in and of course do a little plasty in the cavernous segment. Because at the moment, as you must have noticed, that it is difficult to go inside the thread all the way. This is what it is. Beyond that, it is just not moving. So rather than pushing the LINNC and our microcatheter, I am coming out with the headway. Up to here we can reach for sure, and if at all we require a balloon plasty at the C1, C2 junction in the cavernous, then we would try and do that. For the time being, we have deployed the flow diverter, and let's get a run before I take out the headway.
So obviously it changed the strategy, is using a flow diverter, fried flow diverter, and trying to avoid to, I don't know if he decided to avoid to cover A1 segment, but I will ask him.
Ventilate.
See, for the time being,
Go ahead.
In MCA, along the neck of the aneurysm,
Bone.
this plastic supraclinoid ICA, we are all covered. And it's just C1-2, which is also looking okay. And it's just the inferior portion of the anterior genu, the C2. There also actually we look okay. So at the moment it is looking okay. What I'm going to do, of course, is now take out the headway catheter and try and go in, if I can, in an atraumatic manner with a balloon, and if the balloon goes, then that cavernous segment I will try and do a plasty. So any thoughts? Of course, we had to change completely the strategy which was ready in our minds days ago, but this is what it is. It's real life. I mean, everyone agreed that because of the distal atherosclerotic disease, the MCA was a real challenge, but we did not envisage that the proximal regrowth of the PCOM with its fusiform dysplastic segment also would pose a challenge. At least it did to Leoplast. We changed it to a flow diverter, which is Fred. One of the reasons to do that is also because the microcatheter was not at all stable, and in any maneuver that we had to do with the previous stent, the microcatheter actually was jumping up and down. So it was not really serving the purpose. So we changed the strategy, what we did not want to do. Before that, I'm sure that you saw the shoot from the right side, a small A1. Nevertheless, it is supplying at the moment at least the A1 with both ACAs fill well. The MCA is filling well. The aneurysm is covered and stagnating a little, and the Fred seems to be reasonably opposing. I mean, there are no real alarms here. So I'm going to take the headway out and then try an atraumatic plasty. If it is okay, if it is not okay, then probably we are done with this.
Okay, balloon.
Any comments? Can you hear me? Heparin. Still the guy that probably I've lost two-way connection. I've lost the connection, huh?
Okay, so the strategy is changed, so now the only thing to do is to bet that the anterior cerebral territory, supply of the anterior cerebral territory will stay open. There will be no flow restriction, and the patient will be waking okay. Nobody can say what's going to happen. It's a challenge and the choice of switching from one strategy to the other one. I think the first strategy was perfectly adapted to the case. It happened that there was a problem applying the strategy, so they changed the strategy and they put something which is easier, which is just a flow diverter. No stent, no coils, nothing. But the balance is that you might compromise the patency of A1 segment.
LO 16 cranial 21. Double mark.
You are in the lumen, right?
Roadmap. Stop blinking.
So obviously, Uday is trying to angioplast the stent.
Ventilate.
See that, I don't know whether the fluoroscopy is very clear in auditorium, but from what we can see, more or less it looks to be opposed. Nevertheless, we have got the balloon in, and so it's a short balloon, and I will just try to get a simple angioplasty.
Here, which balloon he is using? I didn't.
This is a single lumen
I
balloon.
was busy speaking with B-Tech on the side.
It's a single lumen balloon, and it's a short balloon transformed by Boston Scientific. 410. It looks to be okay. Let's go back to lateral, please.
Tube lateral. Roadmap off. Stop. Step back to the right.
Save.
So the big advantage when you have a stent already in position, you have very little risk of bursting the vessel because the stent is protecting. So even if you overinflate,
Yeah.
it's okay. And you have to if you want to really oppose the stent to the wall.
Save. Okay, we are done here. Let's get one more run, and if required, we will inflate once more in this horizontal C3 cavernous.
Stop venting. Ventilate. Bone करो. Looks okay. Go back.
There is a question here, the stenotic MCA branch have slow flow.
Yeah, it was the stenotic MCA, both the divisions were slow flow right from the beginning, but we checked it and it is reaching up to the periphery, there is no occlusion, and it is almost the same as what it was when we started. And when I remove the balloon, I guess that it will feel better. Are we seeing that the apposition of the C2?
इसको light करना है contrast.
It's okay, right?
It looks okay.
Obviously, the stent doesn't interfere with the patency of the bifurcation. So
Yes. There are two other things. I mean, there's the
Problem.
endless same discussion. One thing is about the A1, and second thing is about the choroidal, which is also almost coming from the level of the aneurysm. And so anterior choroidal at the time being is filling. Stent in that dysplastic atherosclerotic artery is opposing. We have done an angioplasty, and this is a pretty easy artery to get into. So I'm going to release now our balloon and get a run after waiting for another maybe 15 minutes as usual. This is a little stronger inflation as Jacques was talking about, because more or less we are done here, and the stent seems to be okay opposed.
usually, just a comment, usually when you put the flow diverter in front of the origin of the ophthalmic, we like to have the stent perfectly opposed to the walls.
Yes.
Otherwise, in between the walls and the stent, if it's not perfectly opposed, you might get some small thrombi, and the ophthalmic artery is just ready to take those thrombi. So we like to have the stent perfectly opposed to the wall.
Same.
That's what I know. That's okay, that's already done.
So I saw on the previous pictures from the other side that there is a tiny little A1 segment
It is.
on the right side. So maybe the slowing of the flow due to the deposition of the flow diverter on the left will help the development of the A1 on the other side. So
And let's
it's
hope
not
that
a bad situation
Yeah.
compared to what we saw.
Yeah, let's hope that the ipsilateral one remains patent as so far it is, and just unsubtracted, just for patency. Stop early, good. Okay, so I'm going to take out the wire and the balloon now, and we will take last angiograms in the projections that we were working in, and wait for 15 minutes for the final angio.
Okay.
AP and lateral.
Okay, so according to the change of the program due to the modification of the live cases in Mumbai, we get a little bit more time. So we definitely think about moving a little bit ahead the industry symposium. So probably the industry symposium will be starting in about 5 minutes. So just for what's the industry speaking there, I don't know which industry is speaking now. Nobody is helping me. Jindal, can you help me?
Ventilate. Bone transfer? Yeah, good. Yeah.
Okay, Jacques, so now these angios are done, and then we will wait for 15 minutes for last angios, and then we are done with this case. Are we interactive live? I just want to speak to Jacques. Jacques, can you hear me? Jacques?
Yes, we hear you.
Yeah, okay. Okay, for the time being, you must have seen the lateral and the AP projections, they look okay. And so we have taken out the material and we will wait for 15 minutes for a last angiogram. And thank you so much for this patience, because it required from our side and definitely from your side a lot of patience and understanding. And so so this case is over. The slots that we had for 2 cases, unfortunately our first case itself took those slots. So do I understand that the second one is not going to be live?
Correct.
Okay,
Because
okay.
there we have another
Sure.
different slots of live cases to do, so we cannot come back.
Absolutely.
But this is real life,
Yes.
so don't worry.
Yeah,
It's fine.
no,
The
I'm
best
never
is the
worried.
patient got a good treatment.
Yes.
He's fine. Everything
Yeah.
will be okay, so don't worry.
Okay.
It's okay, no problem.
Thank you so much. See you soon.
Okay, we have a question for you. There is
Yeah.
a question for you.
Yeah.
Cerebral artery, aneurysm and stenosis.
Yes. So we can go
What
back.
do you plan to do with the partially coiled aneurysm in the MCA and the stenotic lesion?
Yes. So, both are a little bit of formidable challenges if you look at the picture. And as I said before in the introduction of the case, that she has been our patient for the last 12 years, and her primary symptomatic aneurysm was the PCOM, which we had coiled, and her third nerve palsies recovered. And now she's 12 years older and 70 years old, and she had some medical problems not really related to either the regrowth or the MC aneurysm, and she had probably an atherosclerotic disease and hypertensive. So she had a contralateral small hemorrhage, which is not related to both these aneurysms, and she has recovered from that as well. So she's a resilient woman, and in spite of our plans to treat the MC aneurysm with 2 stents, we first went in with balloons and we did angioplasty, believe me. And that angioplasty recoiled completely, because this is an atherosclerotic narrowing, probably calcific as well. And the aneurysm is undercoiled, I accept that. But at the same time, the intracranial angioplasty for the inferior division is, we attempted an angioplasty. I was not sure if I could place a stent in that stenotic segment, a balloon mounted stent, in order to open that. So we did not do that when we treated the MC aneurysm. So for the time being, the MC aneurysm is undercoiled. For the time being, she has severe stenosis of the inferior division, and also she has moderate stenosis of the superior division. And you rightly pointed out that she may have more risk because of atherosclerosis, but for the time being, and for the result with the aneurysms and her age, we will accept this. We will accept that this is not the perfect looking angiogram, but hopefully we don't have to go back in again to treat her. That's how we are feeling right now.
So there is question from the audience going through the LINNC application. Is balloon angioplasty really necessary in this situation? What you did on the stent, probably?
Yeah, the question is for me.
Is the balloon angioplasty really necessary
I
in
got
this
it. Okay,
case?
so the original plan was not to treat her primarily for the atherosclerotic disease, intracranial atherosclerosis. The primary plan was to secure the aneurysm, the MC aneurysm. And in order to secure it, you saw the 3D before we started. In order to secure it, there was absolutely no way that we could secure the aneurysm with tight packing and coiling without having to use a double balloon technique and probably 2 stents as well. And so the angioplasty, as far as the symptoms were concerned, was not necessary. But the angioplasty we did nevertheless, because we thought that we will still put 2 stents inside the 2 divisions and coiled aneurysm. But looking at how, it looked good immediately after angioplasty, but within the course of the treatment, when we inflated 2 balloons and coiled aneurysm, and the arteries went back, it recoiled. And so because of that, we did not put a stent there. It was not primarily trying to dilate these arteries, but seeing if the arteries look better in caliber with balloon dilatation, we would have put a stent here. So the indication for us was a little different.
Okay. There is another question for you, which is, do you think there was a possibility to position the Fred stent without covering the origin of A1?
No, I don't think so, because you know what happens here is that you saw that happen if you saw the entire presentation, that the Leoplast, when it came back a little from middle MCA, it came back. This is a very distal aneurysm. The regrowth really is not completely posterior wall. The regrowth really is the ICA terminus. And it's a dysplastic artery, and at the regrowth the artery measures 8 mm. It's a fusiform dysplastic regrowth of the neck, which incorporates the ICA terminus. So coming back and not covering the A1 was not an option, and that was precisely the reason that we chose a Leoplast, that is not a flow diverter stent in the first place. Unfortunately, there was technical glitches that we had, and so we just went ahead with flow diverter, confirming that there was a small little A1 which might hypertrophy, and for the time being, this is a huge A1 which is patent.
Oh, I definitely agree with you. You know, looking at the anatomy, I think the plastic vessel and probably the aneurysm neck is extending much more distal to the PCOM area.
Yes.
So I think there was no possibility to avoid covering A1 segment.
Right.
Is there any other questions from the audience? No. Okay, Uday. So
Okay.
thank you for your participation.
Thank you.
And take it easy. I don't know what the weather you have, but it's fully sunny and wonderful in Paris.
Wow. So well, I cannot
Are we
wait to be
going to
there
see
and
you
meet
tomorrow?
you. Yeah, we will meet tomorrow, Jack. Thank you very much, and thank you for
Thank
all
you.
my team. Thanks a lot.
So see
Thanks.
you. Bye-bye.
Bye.
Bye-bye.
Bye-bye.